Okay, next, we will have an official opening of Cardiovascular Summit TCT AP 2019. First, we will start with a welcome remark and introduction of TCT AP from Dr. Seung-Jung Park, the course director of this meeting. Please give him a big hand.
Thank you. Very happy to be here. Good morning, everyone. Excuse me. On behalf of organizing committee, I'd like to welcome all of you to this year's 24th TCT AP 2019. Today I am very humbled to stand here because it reminded me of the last almost 30 years dedicated lifetimes. At the beginning, look back on the times that this meeting started as a very small one in 1995, and as you see, this year's meeting as it has been grown up as one of the biggest conference in the Asian Pacific regions, having about around 4,000 participants from over 40 countries too. I believe these TCT AP meetings could not exist without your excellent faculties and my friend support. So I'd like to take this opportunity to convey my sincere respect to, first of all, our colleagues and members of Asian Medical Center and staff for CBRF and many affiliated society, especially CRF and TCT members from United States, Marie Leon, Gregg and Gary too. You know that the core concept of our TCT meeting has been sharing the latest data via the diverse live demonstration and featured lectures from leading experts and placing to learn each other from the basic to the up-to-date knowledge in this interventional field. And I definitely sure our TCT AP meeting will continue to play an important role for the future decade to come, and I really hope all of you stay with us together. So, as a course directors, and Dr. Bach will give us a little more detail in our TCT meeting. Thank you. Please enjoy that.
Okay, thank you, Seung-Jung Park. I'm thrilled and honored to introduce this terrific conference in front of the internal and external masters and lots of colleagues in cardiovascular interventional field. There is no question our global distinguished line of faculty enhance the quality and the reputation of this meeting. This was directly linked to proportional increase of participants throughout the world. Since TCT AP has been held in 1995, the proportion of overseas participants has grown steadily. This year, we have over 50% participants from overseas. In TCT AP 2019, around 3,000 participants with over 500 key faculty from 43 countries are taking part in this year's meeting. 35 live cases will be demonstrated from 4 live centers in the world, 420 lectures, and 350 challenging cases and abstracts will be presented throughout the conference. We are focusing on the 4 specialty: coronary, endovascular, structural heart disease, and CTO, and major session. Through this session, we can experience up-to-date knowledge from various subjects involving left domain, valve, imaging and physiology, complex PCI, antithrombotics, renal denervation, CTO intervention, and the endovascular intervention. In major clinical trial session, the latest breakthrough research of cardiovascular intervention will be revealed, and new data from affiliated hospital as a medical center will be shared. The featured clinical research from abstract will be presented and published online into supplemental issue of JACC. This year, we had ACT alumni for the 10th anniversary of our ACT program. Through this monthly meeting, we provided the practical learning opportunity to over more 1,600 doctors for last 10 years. We hope our ACT alumni become inspired, and this year TCT AP meeting brings innovation to their daily practice. To expand educational sharing, the newly refurbished training center will be held with 6 hottest to interesting topics. Thank you very much for all our faculty members, every staff, and attendees. All your effort and the sincere devotion have made this conference possible. Hope everyone have enjoyable and wonderful experience at TCT AP 2019. Thank you for your attention.
Thank you, Dr. Park. Next, there will be a congratulatory remark from Dr. Kee-Sik Kim, the course director of the Korean Society of Cardiology. Please, Dr. Kim.
Good morning. Good morning, everyone. On behalf of Korean Society of Cardiology, I'm really honored to have this remark for TCT AP 2019. And I would like to congratulate you all for the successful opening of TCT AP 2019. As you know that, the TCT has become an essential course not only in the Asia, but over the world. In this course, various programs encourage the attendee, providing the chance to meet the numerous clinical investigations and the techniques and the treatment strategy. For this purpose, I know that how hard Dr. S.J. Park and other all faculties and staffs are trying to provide the best opportunity to integrate the newest investigations and the techniques and to review the new outcomes for all health professionals. With their effort, I don't doubt that this course will be valuable and very wonderful experience for all of attendees. Lastly, I'm really happy to be part of this course and hope you all enjoy the rest of this meeting. Thank you very much.
Thank you very much, Dr. Kim, for your warm and kind words. The second congratulatory remark will be given by Dr. Martin Leon from the Columbia University Medical Center. Please give him a big hand.
Thank you very much. It's such a pleasure to be here. So we want to welcome everyone. We want to send our congratulations, certainly from your friends at the Cardiovascular Research Foundation and everybody who's involved in TCT, which this year will celebrate its 31st anniversary. But this was the first TCT back in 1988. And it is interesting that we had a very defined purpose. We certainly wanted to focus on this new era of innovation. We believe that the live case demonstration format for educational purposes was important. You just saw that in the live case, how important it was to have these discussions. We believe that evidence-based medicine, rigorously applied, was going to define our field, and we felt that it needed to be international, global, and multidisciplinary. So these were the original purposes of TCT more than 30 years ago. Now the last TCT in San Diego, we had close to 12,000 people, more than 90 countries. We had a very large faculty of over 1,400 with many lectures, abstracts, challenging cases, late-breaking trials, last year highlighted by COAPT. Many live case sites. Training became a new emphasis for TCT, so we continue to evolve with each year as the field continues to evolve. But I also believe certainly the TCT AP has been a phenomenon. And we want to celebrate that phenomenon now in 2019. So what are the components of a successful educational meeting? You have to have great leadership, content, faculty, venue, good clinical site staff and operators, great support from industry and participants, and a great organizational management as well as many intangibles. And all of these things are embedded within the TCT AP framework. You also have to have a great leader. And I want to again emphasize that S.J. Park has been a friend, has been a leader. He was one of the TCT Career Achievement Award winners. And over the course of 24 years, he has been an overwhelming presence at this meeting. We've had a wonderful opportunity to work with S.J. I have to mention that Gary Mintz has been embedded in this course for so many years. Masters like Antonio Colombo, live case opportunities involving many of your colleagues from the Cardiovascular Research Foundation. Really, it's been a process where we grew together for so many years. At the same time that PCI has changed, beginning mainly with coronary, bringing in the vascular component. Now we talk about structural. So when we think of PCI, we don't think about it as just coronary intervention. We think of it as percutaneous cardiovascular intervention. And this has been embedded in the TCT AP structure. We also believe that as PCI evolves, you have to integrate the clinical imperatives, new technology, and evidence-based validation. And this is the central component of TCT Asia Pacific, which is why we're so excited to be here and to continue to have this partnership relationship. And finally, yes, it's all about the patients. We desperately care about bringing the best therapies to our patients. So whether it's drug-eluting stents, or the first transcatheter valve, or some of our favorite patients, I think everybody has to be aware that your patients are the point of care, and TCT AP has always been patient-focused. So congratulations and best wishes for a successful meeting for TCT Asia Pacific. We are thrilled to be part of this wonderful experience.
Thank you, Dr. Leon. Following the congratulatory remark from Dr. Leon, we will have two keynote lectures from Dr. Leon and Dr. Gregg Stone. First, Dr. Martin Leon will give us a talk about the future of TAVR, a master's perspective. Please.
I'm not so sure that I'm a master. I know that we have a Master of the Masters Award, but the person who's going to be getting that award this year, Patrick Sarais, is a Master of the Master of the Masters. So I have to say that it's really a pleasure to be here when Patrick has been given this honor. In 10 minutes, there's only so many things I can say, so I will go very quickly and give you at least some sense as to what's been a less than 20-year evolution of an exciting area, which you saw demonstrated in the earlier cases. You've already seen one of my heroes, Alain Crebier. I want to spend a moment telling you about this first patient. which is 17 years ago. He was 55. He was in cardiogenic shock. He had multiple previous balloon aortic valvuloplasties, an ejection fraction of 10%, severe ischemic limb disease, so this procedure could only be done via a transseptal approach, had a large LV thrombus, and also had a bicuspid valve. This case was done without general anesthesia, without transesophageal echocardiography. This is the first case that was done. Now, I spoke to him after he accomplished this feat, and we discussed, well, what is next? We couldn't really understand what the next steps were, but no one could have predicted that this field would have grown and evolved so quickly over the last less than 2 decades. And it's evolved because of the rapid technology evolution, procedural refinements and simplification, an avalanche, a tsunami of TAVR clinical evidence, the acceptance of the heart valve team, and this has resulted in explosive growth worldwide. When we look at the United States, you can see over the next many years, we expect a 2.5-fold increase in the number of cases. And by 2025, more than 3/4 of aortic valve replacements in the US will be transcatheter and not surgical, and these are probably conservative estimates. But I will tell you, as we talk about the future, we should discuss the recent past, because unless we could conquer low-risk patients, then TAVR would always be limited. It's important because the holy grail was the 80% of aortic stenosis patients receiving surgery who are in this low-risk category, the dominant group of patients who still receive cardiac aortic valve replacement. We certainly have had good data in the partner trials in extreme risk, in high risk, in intermediate risk, but we did not know what TAVR could accomplish in low-risk patients. This is the primary endpoint outcomes. This is a triple composite endpoint of death, stroke, and rehospitalization, looking at surgery, and then looking at SAPIEN 3 balloon expandable TAVR. We did not expect these results. This was meant to be a non-inferiority trial, but we could not have predicted that it would be superior to surgery in this low-risk cohort. In particular, if you look at death and disabling stroke, only 1% of patients had either death or a significant stroke at 1 year in these low-risk patients, almost 1/3 of what was achieved in surgery. Now, importantly, this was replicated in another low-risk trial where, again, lowers death, disabling stroke, and rehospitalization with self-expanding TAVR versus surgery, and even better hemodynamic outcomes than our surgical predicate in this more than 1,000 patient randomized trial. So now the conversation has changed. The guidelines haven't yet, but ultimately I think they will, hopefully shortly. And where we used to say, we use TAVR in patients who do poorly with surgery, what we now say is that we really should be thinking TAVR first, and to select those patients who we think will do well with TAVR preferentially. Now, what will the future bring? Well, the success of TAVR has catalyzed a second wave of clinical studies that will explore the expansion of clinical indications, and I've listed them here. High up on the list is bicuspid aortic valve disease, but I want to mention one in particular, a fascinating study that we're deeply engaged in, the early TAVR trial. So this is an 1,100 patient trial in 75 US sites looking at severe asymptomatic aortic stenosis. We've enrolled approximately 400 patients. This will be another landmark trial to see if asymptomatic severe AS would be another candidate for TAVR. There are many innovative TAVR-related technologies which are being explored. You're going to see a lot of work on the valve material itself, a lot of interesting work with tissue engineering and prosthetic valve materials that I think may transform and change both the thrombogenicity and durability of heart valves in the future. You're also going to see that access to AS patients will change. This is a fascinating novel imaging technology where image acquisition is done with point-of-care handheld devices. And you can train anyone to get a good echocardiogram to assess valvular heart disease, and using artificial intelligence and deep machine learning, the machine itself will tell you if there's significant AS or MR in these patients. These technologies are important to better access the group of patients who we think are treatable. There are new aortic valve remodeling technologies like this. This is not valve replacement that may have a variety of roles. This has entered clinical trials in the future. We also think that the AS classification scheme and therapy trigger points may be redefined. My colleague Philippe Généraux has done a nice study looking at staging classification based upon what we call the extent of cardiac damage, as AS affects the ventricle, the atrium, atrial fibrillation, pulmonary hypertension, and right heart failure. This has a very important effect on outcomes after TAVR. So treating earlier before you get the accumulated magnitude of disease on the left and right heart may be an important change in therapy trigger points. And finally, there are many gaps in TAVR knowledge which have to be addressed. We still have issues about valve leaflet abnormalities, late TAVR structural valve deterioration and durability, which we are assessing. We talked about coronary access considerations earlier and optimal adjunctive pharmacotherapy. There's no question when you put in a bioprosthetic valve, 5 years, 10 years, 15 years, you're going to see these kinds of outcomes, and how to manage these patients will be a great challenge for us in the future. We also believe that as you treat younger patients, that access to the coronaries is also an important consideration. Possibly commissural alignment will be significant for these new valves. So a lot of new work is being done in this particular area. But by all meaningful criteria, TAVI has been a breakthrough technology in the management of patients with aortic stenosis. I think no one would argue this. And I think finally now with the PARTNER 3 trial and the Evolute low-risk study, we can fill this last quadrant with good evidence from 2 large, well-conducted clinical trials. And this makes a difference for all of us. So I'll end by saying, what do Henry Kissinger and Mick Jagger have in common? They are both the proud recipients of TAVR therapy in New York City. Thank you.
Thank you, Dr. Leon. The title of the second keynote lecture is Mitral Valve Future Perspective. Dr. Gregg, please.
Thanks. So again, it's a pleasure to be here. I've been coming to TCT AP now for more years than I can remember, and this has always been and continues to be one of the shining monuments to interventional cardiology in Asia. And it's a pleasure to have helped play a small role from the Cardiovascular Research Foundation in SJ and all your colleagues' success. So congratulations on the 24th edition. So not, again, too much I can say in 10 minutes, but I'll try to give you some highlights of the future of transcatheter mitral valve repair and replacement. So in contrast to aortic stenosis, which is for the most part one disease, and at least greater than 90% of the patients, the mitral valve disease is very, very complex. And there's multiple different etiologies, and there's multiple different kinds of therapies, not just aortic valve replacement. So it all starts when we think of severe mitral regurgitation by breaking it down into either primary or degenerative mitral regurgitation or secondary or functional mitral regurgitation. And you have to think of these as 2 very separate diseases with different therapies and different outcomes. We know that for primary degenerative MR, medical therapies don't help. Surgery is class 1 in the guidelines. While there's no randomized trials, it returns patients to their age and sex-matched survival status. It's a very durable procedure, especially when a good repair is done. And in the Everest 2 trial, surgery was superior to the MitraClip. So transcatheter mitral valve repair is thus reserved for prohibitive risk patients who cannot be repaired surgically. But for secondary or functional MR in heart failure, it's a very, very different story. Here, the primary therapies until recently have really been aimed at the underlying left ventricular dysfunction, and that is drugs for heart failure and cardiac resynchronization therapy. Defibrillation, revascularization is appropriate. But surgery had never been demonstrated to be beneficial in these patients, perhaps a little bit of symptomatic relief, but high morbidity and mortality procedure in these elderly patients with multiple comorbidities. Similarly, until recently, we didn't understand much about transcatheter mitral valve repair in patients with secondary mitral regurgitation due to underlying heart failure. So again, a lot of the early knowledge about transcatheter mitral valve repair, you know, came from the Everest 2 trial. This, at the time, was the largest randomized trial in mitral valve therapeutics. We didn't even realize how important it was to separate degenerative and functional mitral regurgitation. So they were combined in this program as if they were one disease. 3/4 of patients with degenerative MR, low-risk patients compared to surgery versus the mitral clip. And of course, the interventional approach was much safer, but surgery was overall more effective. When you looked at subgroups to see if there was anything we can see within this trial that might favor transcatheter mitral valve therapy, there was only one thing that came out, and that was functional versus degenerative MR. At both 1 year and 5 years, it seemed as if the patients being treated with mitral clip compared to surgery were doing similarly, whereas the degenerative MR patients clearly benefited by surgery. Now, there were a lot of issues with this trial. This was the early learning curve of the mitral clip device. Success rates have gotten much higher, et cetera, et cetera. But the question came back to this functional MR group. Did these patients really do as well with the mitral clip compared to surgery, or did neither therapy really benefit the patients? And that's why the results are neutral. So based on this, of course, the FDA back in 2013, at least in the United States, approved the mitral clip for treatment of prohibitive risk patients with degenerative MR, but said nothing about secondary or functional MR. And what happened in the United States is that because of reimbursement patterns, almost all the patients were treated with degenerative MR. These are high-risk surgical turndowns, so over 95% of patients had degenerative MR. But in Europe, a very different pattern emerged, and the rest of the world, where the majority of the use of the mitral clip was for functional MR, based on registries suggesting that this procedure could be done safely and patients would receive substantial symptomatic benefit. But did this really improve the outcomes that mattered, that is death, heart failure, hospitalization, and other hard endpoints? Well, we know that the severity of functional mitral regurgitation strongly relates to subsequent prognosis, both death and heart failure hospitalization. In multiple different studies, quantitatively, the more MR, the worse the prognosis. But for most people, this was thought to be a marker of underlying left ventricular dysfunction. Even after multivariable correction, it persists, but nonetheless, most heart failure specialists would look at an echo, and if they see an EF of 30%, then whether or not they see severe MR, pulmonary hypertension, right ventricular failure, TR, it doesn't matter. The LV was the predominant disease, and the others were just treated conservatively. So 2 trials address this, looking at the mitral clip versus conservative medical therapy in patients with heart failure and secondary severe mitral regurgitation. On its face, these 2 trials look pretty similar. The MITRA-FR trial in France randomized 304 patients with secondary MR due to LV dysfunction, ejection fractions of 15 to 40%, NYHA class 2 to 4, 1-to-1 to either medical therapy or the mitral clip. And this was a great disappointment because there was absolutely no difference in death or heart failure hospitalization. The procedure was safe, but no benefits. And this supported the opinion that came out that, well, probably severe mitral regurgitation is just a marker of the underlying bad disease, so fixing it doesn't make a difference. Well, at the same time that trial was enrolling, we were enrolling the COAP trial, which was a larger, somewhat more ambitious study of 614 patients using a more rigid or rigorous criteria of severe mitral regurgitation, which I'll describe. And these were patients who had been maximally treated and were failing all guideline-directed medical therapies and CRT if appropriate, randomized 1-to-1 again to mitral clip versus guideline-directed medical therapy alone. We followed the patients out for 2 years, and in contrast to MITRA-FR, saw dramatic reductions in heart failure hospitalizations and improvements in quality of life. And you could see immediately in this patient population, after reducing left atrial pressure and volume override by the mitral clip, patients immediately felt better and had a marked reduction in heart failure hospitalizations with a number needed to treat of 3 patients to prevent 1 heart failure hospitalization within 2 years. In addition, all-cause mortality was substantially reduced by the mitral clip. You could see a 17% absolute reduction in all-cause mortality. You can see how sick these patients were. Almost half of the control patients died in 2 years. Relieving their mitral regurgitation didn't cure them. We still had a 29% mortality rate because there is still the underlying LV dysfunction. But we did save 1 out of 6 lives, at least within a 2-year period, giving them more time. And so the number needed to treat to save a life was only 6 patients. So the real question, which I think is going to guide this field in the future, is why were there differences between these two trials, which on their face looked so similar? Well, I've got a series of talks at this meeting. I'm going to go through this in much more detail, but we believe that there are three main reasons. The first is that COAPT enrolled patients with substantially worse mitral regurgitation with substantially smaller ventricles. So the extent of the MR was hemodynamically more significant compared to the degree of left ventricular dysfunction. And this was really a criteria because we put in a cap on how large the left ventricle could be in COAPT compared to no cap in MITRA-FR, and we used a more rigorous definition of what is severe MR in COAPT than was used in MITRA-FR. Second, the medical therapies were not maximal in MITRA-FR and were allowed to vary, and we believe that the control group was overtreated in a good way during follow-up, which minimized any differences, whereas COAPT, the patients basically had nowhere to go because they had already been failing all maximally tolerated doses of guideline-directed medical therapies. In addition, the operators in the COAPT trial had been using the MitraClip for, many of them, up to 10 years in 5 different studies, and were very, very experienced compared to the French operators for whom this was the registration trial. And as a result, the acute procedural success rates were higher, the complication rate was lower, and perhaps most importantly, the durability of relieving severe mitral regurgitation was substantially greater in COAPT than it was in MITRA-FR. So this led to, several weeks ago, the FDA now rapidly approving the MitraClip for treatment of selected patients with secondary MR who were made symptomatic despite guideline-directed medical therapy, basically using the COAPT criteria. So this now leads us to the device landscape. And this is something I've been keeping track of as much as I can for the last decade. And there have been over 60 devices, actually almost close to 80 now, that have been developed to treat the multidimensional disease state of MR. There's edge-to-edge techniques. There's direct and indirect annuloplasty. There's more than 35 kinds of mitral valve replacement devices, which everyone was hoping was going to be as easy as TAVR, but clearly is not. And then there's other approaches. There's spacers. There's neocords. There's P2 leaflet replacement technologies, et cetera, et cetera. So why do we need so many different devices? Well, the surgeons are not limited to one type of repair or replacement. That's why mitral surgery has advanced over the years, because there are so many different etiologies and deformations of the valve, and not only the valve, but the cords and the papillary muscles and the underlying myocardium and the annulus itself, that you need different types of repair and replacement for different scenarios. So the COAPT trial does have implications for all of these new repair technologies because it was so positive, such a marked reduction in mortality and heart failure. For the mitral valve repair technologies, the question is going to be, will they be as safe as the MitraClip? Will they be as effective as the MitraClip? Will they be as durable as the MitraClip? It was extraordinarily durable because it addresses the primary pathophysiologic insult in secondary MR, and that is the lack of leaflet coaptation. Will they be able to treat the same or different patients as the MitraClip? For example, the MitraClip can have trouble with mitral annular calcification, wide or multiple jets, extreme tethering, small annulus, risk of mitral stenosis, etc. And perhaps these devices will be able to treat MitraClip failures, or perhaps the MitraClip will be able to treat their failures, or the devices may be complementary with each other and synergistic in being able to give you a better repair. For the mitral valve replacement technologies, the metric is somewhat easier, given the likelihood of greater procedural complication, the need to anticoagulate, but also the likelihood of elimination of mitral regurgitation in the vast majority of patients with TMVR. Will this clinically be more effective than the MitraClip, or will you be able to treat MitraClip ineligible patients? So there are advances, and I'm just going to highlight these very quickly. You know, the MitraClip, of course, is not standing still. Now there's new generational devices of this, which is making grasping the leaflets easier with a larger material. Pascal is a somewhat different technology, which also approximates the anterior and posterior leaflets. It has a wider and deeper set of paddles, which are independently functional, which may make use of a single spacer, in most cases feasible, so you don't need multiple clips. We'll see if this is as safe or as effective. There's a trial called CLASP ID, which is an ongoing study, which has started comparing the Pascal device to the MitraClip in 675 patients with severe degenerative mitral regurgitation and prohibitive risk for mitral valve surgery. There are 3 other randomized trials of mitral valve repair that have begun using an indirect annuloplasty approach with the Cardiac Dimensions Carolyn device, direct annuloplasty with a semi-flexible direct annuloplasty device on the left atrial side with the Cardioband, and then a neocord DS1000 device, which is using, through a transapical approach, PTFE neocords for treatment of DMR, while these other 2 annuloplasty approaches are for functional MR. These trials have started. One of them is on hold. They're enrolling slow. They may have to be somewhat redesigned, but at least we have other pivotal trials ongoing. And then finally, there have been at least 12 transcatheter mitral valve systems which are in human use. Pivotal trials started for 2 of these, the Abbott 10-9 device and the Medtronic Intrepid device, again enrolling relatively slowly. We'll see if these trials, again, have to be somewhat rethought and redesigned, but it's very exciting that we're going to have complementary and novel ways to treat mitral regurgitation and degenerative MR. So if I was to summarize and give a 2009 status update, more than 60 transcatheter devices have been developed to address the multidimensional disease state of MR. 1 device, the MitraClip, has been firmly established and is widespread use in the US and Europe. 4 others have CE mark in Europe. Most have been used in small number of patients or are still in preclinical testing. And yes, more than a handful have failed, which I didn't review. The COAP trials demonstrated that the MitraClip can improve prognosis, reduce mortality in selected patients with heart failure and secondary MR who remain symptomatic despite maximally tolerated guideline-directed medical therapy. And this truly represents a paradigm shift for heart failure therapies in general. And then finally, annuloplasty devices, neocords, transcatheter mitral valve replacement, and other novel approaches offer great potential to expand treatment options for patients with severe primary and secondary MR, and these studies are ongoing. Thanks very much.